I'm Dr. Lauren Beretich, Medical Science Liaison of Organ Health at Natera. I'm pleased to discuss with you an article titled Clinical and Genetic Features of Autosomal Dominant Alport Syndrome, a Cohort Study. This article was published in the American Journal of Kidney Disease in October of 2021 by Furlano et al. Alport syndrome is the second most common genetic kidney disease, which is related to about 2% of patients receiving a kidney transplant. While classically described as hematuria with progressive kidney disease, hearing loss, and ocular abnormalities, this is typically related to X-linked Alport syndrome, that which is caused by COL4A5 variants. Alport syndrome related to variants in COL4A3 and 4A4 may be more mild. All this to say, Alport syndrome is a spectrum ranging from benign hematuria to the typical presentation described. Because of this phenotypic variation, there has also been variation in the nomenclature for various Alport syndrome-related genotypes, notably those heterozygous for a COL4A3 or 4A4 disease-causing variant. The authors note that there is growing agreement that these heterozygous individuals should be considered to have autosomal dominant Alport syndrome. The authors also note that previous attempts to provide phenotypic details of individuals with a heterozygous disease-causing variant in COL4A3 and COL4A4 have limitations, including small sample size and sampling bias. So, the goal of this study was to provide an in-depth analysis of clinical features and types of variants in a large cohort of families with heterozygous disease-causing variants in COL4A3 and COL4A4. This study included 82 families and a total of 252 individuals. All were referred from Spanish hospitals between 2000 and 2019. Each family had an index case who was heterozygous for a disease-causing variant in COL4A3 or COL4A4. In all but one family, genetic testing was performed due to an autosomal dominant inherited microhematuria and proteinuria, and/or CKD, or an abnormal glomerular basement membrane. In this cohort of individuals, 56.3% were women and 43.7% were men. The mean age at diagnosis was 33.6 years. Interestingly, no significant differences in kidney survival based on sex were identified. Not surprisingly, 92.1% of patients had hematuria. Of 20 patients without hematuria, 16 belonged to families in which someone had been diagnosed with autosomal recessive Alport syndrome. Patients without hematuria did not exhibit proteinuria. 65.5% of patients had proteinuria, and among those with proteinuria, 38.9% received kidney replacement therapies. None of the patients without proteinuria needed kidney replacement therapies. Overall kidney survival was 67 years, and for patients with proteinuria, overall kidney survival was 58 years. In this cohort, hearing loss and ocular abnormalities were also uncommon. Figure 3 shows the intrafamilial variability of autosomal dominant Alport syndrome. The circles indicate present age of patients who are not undergoing kidney replacement therapy, and the red symbols represent age at the start of kidney replacement therapy. You can also see that the age of kidney replacement therapy is variable within and between families. This bar graph details the type of disease-causing variants identified. You can see from the key that these variants vary from missense, splicing, nonsense, as well as indels. The mean age at kidney replacement therapy was 64 years for individuals with a variant of COL4A3 and 69 years for individuals with a variant in COL4A4. This difference was not statistically significant. There was also no significant difference in age of kidney replacement therapy by variant type. The authors note that this is the largest known cohort describing the clinical and genetic features of individuals with autosomal dominant Alport syndrome. The prevalence of autosomal dominant Alport syndrome is thought to account for at least 20% of all Alport syndrome when we take into consideration the phenotypic spectrum. Clinical findings beyond hematuria are highly variable, which makes autosomal dominant Alport syndrome challenging to diagnose in many cases. This variability may also explain some cases of CKD due to unknown etiology, especially if these individuals have hematuria and/or a family history. An accurate diagnosis of autosomal dominant Alport syndrome allows for genetic counseling for individuals and families, potentially the avoidance of kidney biopsy, and appropriate management based on that diagnosis. It seems appropriate that further research is vital to identify predictors of rapid progression for individuals with autosomal dominant Alport syndrome and bring newer pharmaceuticals to market to treat these individuals as well. Thank you for your attention. I would encourage you to read this article for more details. For any questions about incorporating genetic testing into your practice, please reach out to your local medical science liaison at Natera. Stay well.